conversational, it promotes conversation that are designed to empower them ultimately to take services that they need. So working with the National Department of Health, we started by co-designing the product with young people. Then we went to feasibility testing where we worked with 42 youth and health experts. And what we were looking for, it was technical stability and also clinical validity, and to ensure that the chatbot does what it's meant to do. From there, we went to acceptability testing with 123 youth, and here we're testing perceived acceptability, perceived use, ease of use, and also usefulness, and if the chatbot will be acceptable by young people. And we also did that through quantitative and qualitative means. Then from the results that we got, the self-CAF as a chatbot was highly acceptable and was technically sound, and it did not have any challenges. So you can see 100% of uptime. You can see that young people, 85% of them thought that the chatbot was easy to use, it was easy to navigate, and then almost 78% of them said that the chatbot was useful for getting HIV-related information. And when we went to them furthermore, is that 41% of young people were retained and they came back after 30 days and they continued to have conversation with the chatbot. But more importantly, 24% of them were linked to services. And these are HIV testing and also contraceptives. Hereby, we are addressing two syndemics, which is HIV and also teenage pregnancy. And then what we also realize is that trust and continuously talking to the chatbot lead to a person having some fears about testing and having some fears about taking the services. But after talking to the chatbot, after the chatbot has relayed the message, young people, they feel comfortable and they end up taking services. Continuously, when we look at, from the qualitative, what do young people tell us? They saw the chatbot as sort of like their big sister because of it was highly anonymous. They found that the chatbot was a safe space for them because of it was not judgmental, and they could relate with the chatbot, and because of it was not algorithm based, they were able to disclose and they were able to freely talk to the chatbot. At the comparative analysis, and this is not a clinician versus AI or AI versus clinician. What this slide talks to us is that there is a need for coexistence, and then there is a need for hybrid services to young people because of one mode of care will not necessarily reach to them. So the conversation that they had with the chatbot, were around teenage pregnancy, were around how to navigate safe condom usage, and they were also around how do they see early signs of teenage pregnancy and what can they do about that. And then with healthcare providers, the conversation was more about direction to the clinic, information about PrEP. So that is why we are saying AI and human beings can coexist in order to give complementary services to young people. Furthermore, people might ask to say, how safe is this AI? It was developed in South Africa by South African, but more importantly by young people themselves who were leading the development. So we've got a first level where the AI does the initial vulnerability assessment, the AI does healthcare provision, and the AI talks to a young person, identifies some patterns. Then the second stage at the background, we've got natural language processing that has been trained to identify, risk, GBV, self-harm, and any other signs that this young person may need agents' health services. Then, as soon as when the AI makes this, determination, we then have a human being in the loop and the human being is able to then link the person to services, is able to give that therapeutic touch, therapeutic conversation to reassure a young person until they can get the services that they are looking for. At the background, we have a hybrid M&E system that monitors the AI not to hallucinate and also not to give wrong information. And these are the safety measures that we have put in place so that we protect young people, we protect the users, and we make sure that the chatbot itself is a safe space for young people. As I'm about to go to closure, what is also important about this AI is that most of the 30% of the conversation, they happened, after clinic hours. In South Africa, we start from 8 until 4, and we saw that most of the conversation were happening between 6 to 10. And this is when young people are back from school and they're back from work and also from their daily work, and they are able to then have a decent conversation and get information about their own health and well-being. Furthermore, um, because of this chatbot has been highly acceptable and young people have accepted it, working with the National Department of Health, we ask us what needs to be done from here, where to. So we are planning to scale up this innovation, and we are also planning to continuously work with other partners within the same environment to make sure that we continuously innovate, because of young people are also not static. So we want to support through the chatbot 6 months multi-month dispensing. We want to infuse as it part of appointment reminders, and also to assist young people to count the pills and to make sure that this becomes their friend that they can depend on for their own health and well-being. We are also going to inject in it U equals to U, and be intentional around U equals to U for those that are already on treatment. We are going to use the very same chatbot to support the long-acting injectable, because of we have seen that young people are having this conversation, and therefore we can support the PrEP agenda and be able to use the chatbot as a form of demand generation linkage to CAM. More importantly, South Africa is in the process of integrating self-injectable contraceptives. And with this, we may be able to have step-by-step guidelines. It will be able to answer uncomfortable questions that they may not have received from the clinicians. It will be able to also remind them about, the injection date, and it will be able to tell them about the refill for their medication and managing the side effect and ultimately health information. In conclusion, the prevention or wellness, be it mental health, youth health, it is located within hybrid model, and it needs to be culturally congruent or resonating with young people, and it needs to complement the existing services so that young people can get comprehensive and complementary services. So we need to invest, we need to partner, and we also need to scale up the services because of young people do welcome, digital interventions. These are people that we want to acknowledge. First and foremost is young people who participated into the study, National Department of Health, BY's partners, and our supporters. Before I can sit down, those who are having smartphones, you are more than welcome to scan the QR code. Those are simple steps that will tell you how does the self-gov work. And I want to congratulate National Department of Health for innovating this for young people in South Africa. Thank you.
Thank you very much, Mr. Potsane and Madam Gertrude. We will have an online presentation. Is he ready now? Okay, so then now. So when they are ready, we'll introduce the speaker. But for now, we have Dr. Maxime Inghels. I hope I got that right. He's a research fellow and looks at impacts of financial incentives and male-targeted app on young female HIV incidence and male HIV-related mortality. a cluster randomized trial. Over to you, Dr. Angel.
Can I get the presentation in? Yeah, please. Sorry, I need some height issue. Yeah, got presentation. Yeah, it's not there. Oh, good. Well, thank you. Sorry for these technical issues. Good afternoon, everyone, and very pleased to be with you this afternoon and to introduce some of the results of our research on the impact of financial incentive and a male-targeted app on young female incidence and male HIV-related mortality. So we conducted our research in South Africa, in KwaZulu-Natal, a region which is known for having one of the highest HIV incidence in the world. And as you can see on that figures, HIV incidence is particularly high among young women. The HIV incidence among men is a bit lower, but their progress through the HIV care cascade is much more suboptimal compared to women, because about a quarter of them are not aware of their status, and only 41% of them are not linked to care. So to address those gaps, we aim to consider two types of intervention. So one, which was a conditional financial incentive for accepting a home-based test and linkage to care. And the second was an app-based counseling, which aim as well to improve HIV testing and linkage to care. And we wanted to see the impact of those two interventions at the population level on HIV incidence and HIV-related mortality. So, as I say, our two interventions. So the first, the conditional financial incentive, was a small micro incentive of 50 rand, which is about $3, which was given under the form of a food voucher, and which was given conditional of accepting a home-based HIV testing. If the result was positive, then a subsequent food voucher of the same amount was offered if the person was linked to care within 6 weeks. For the app, mail-based decision support application, so there was actually two. There was the Epic HIV one, which was designed to motivate men to get tested, okay? And the second app was designed for men who were HIV, who were living with HIV and not linked to care, as a way also to motivate them to be engaged in care. So it was a 2x2 factorial design trial with the first arm with only the financial incentive. So in the HIV surveillance area, every household were contacted, invited to participate to the study, and were offered home-based HIV testing and been told that if they were accepting that home-based testing, they would be given a food voucher of $3. If tested positive, then another subsequent voucher would have been given conditional of being linked to care within 6 weeks. In the second arm, which was the app-only arm, after contacting an household, every man in that household would have been given the opportunity to interact with the app, and after interacting with that app, a home-based HIV testing would have been offered. For those tested positive, they have been redirected to the nearest HIV clinic. If they were not linked to care within 4 weeks, then we would come back to their house and offer them to interact with the second app, again, as a way to improve their linkage to care. The third arm was a combined arm with both the app and the financial incentive. And the last arm was a control arm with only the home-based HIV testing offer. So for the analysis, as I said, so the trial was done during the year in 2018, but we tried to see the impact of the intervention at the population level over the an HIV surveillance area. And so we took a 10 years period, 5 years before and 5 years after the trial to monitor the impact of that intervention. And so for the HIV-related mortality among men, we include all who were living with HIV during that period. For the second outcome, HIV incidence among young women, we include all women with a documented negative HIV test result, followed by at least one subsequent HIV test and residing in the area. So this is a flow chart for the year the trial was implemented. So on the 33,000, more than 33,000 people were living in the HIV surveillance area. Among those eligible, so all those who were not either dead or moved out of the area, about 70% of men were contacted and 80% of women contacted. And what we found, as you can see here, is the trial for the two arms, so one with the conditional incentives and one with the combined arm. They were able to test about a quarter of male residing into the HIV surveillance area, compared to the two arms without financial incentive were only 70%. So there was an increase of 50% between the conditional incentive and non-conditional incentive arm. For the app, it didn't have any effect on the home-based testing uptake. Same result for the woman, when we found an increase into the home-based techniques uptake in the conditional financial arm. And so this increase of testing uptake led also to more case detection. Although in some of those new case detections, there was also people who were already aware of their status, but not yet linked to care. And for the linkage to care, we found that it was pretty much similar, so no effect on none of the intervention on the arm for men, but for women, they were 3 times more likely to be engaged in the arm with the financial incentive. So now we are talking about the impact at the population level. So to do that, we leverage on 10 years of data, and for the HIV-related mortality, we were able to identify more than 3,000 men living with HIV and residing in that area during the 10 years period. And what we found is that the trial actually were only able to reach about 1/3 of them, so there was a rich issue, a rich challenge at that aspect. But for the woman, so we included close to 7,000 women over the 10 years period, and among them, about close to more than 2/3 of them were reached by the trial during in 2018. So this shows you the trend of HIV-related mortality among men. So as you can see, over time, that trend is going down, which is expected because during that period, the coverage of area T have improved. So that was an expected result. Also, as you can see, none of the arms were able to accelerate that decline. The same observation was done among women, so young women, when the HIV incidence did decrease over the study period. But again, none of the intervention were able to create more difference after the intervention. And so as a conclusion discussion, so we see that there was a declining trend in HIV-related mortality and incidence, but none of our intervention appear to have been able to accelerate that decline. And there was a limited effect of the digital counseling, which can be also due to the number of individuals who receive the intervention, because although it was conducted in HIV surveillance area with quite a significant number of people, at the end of the day, the number of people who were new cases were actually small. And so the number of people who benefited from the second intervention, the digital counseling, were actually less than 40, which can also explain why we didn't see any difference. And so that means that further evidence is needed to evaluate the impact of digital decision support tools in this context. And I thank you for your attention, and I'd like to also thank my colleague and the participant of this trial. Thank you very much.
Thank you very much, Dr. Inghels. Is our online speaker ready?
Yes, I'm ready.
He is Dr. Peter Mikago, a public health specialist with over 9 years experience in HIV programming. And his presentation is on leveraging digital technologies to improve cervical cancer screening and management amongst women living with HIV in Eastern Uganda. So over to you, Dr. Mikago.
Thank you very much. Is it possible for my presentation to be shared? Okay, can you see the presentation? Hello, are we able to see the presentation? Are we able to see the presentation? Can we confirm if the presentation is being seen? Okay. Kindly confirm if you can see the presentation. Hello? Good afternoon. Are you able to see the presentation? Good afternoon. Are we able to see the presentation? All right. Thank you very much. I'll be taking us through a project that is titled Leveraging Digital Technologies to Improve Cervical Cancer Screening and Management Among Women Living with HIV in Eastern Uganda. I'll begin with the project context. So this was a project which was implemented by an organization called Uganda Protestant Medical Bureau that was funded by previously USAID. And Uganda Protestant Medical Bureau was the implementing partner that was supporting 198 facilities across the country in the different sub-regions of Uganda. And very particularly in the Eastern region, we had about 72 ART sites in Eastern region. As we may know, cervical cancer commonly affects the women living with HIV because they are at a higher risk. And as such, the Uganda Care and Treatment Guidelines for HIV recommend screening for women living with HIV, particularly those who are at a higher risk between 25 to 49 years of age. And so our project leverage on digital technology to ensure that these women who are at a higher risk actually screened for cervical cancer, leveraging on the technology. So we particularly noted some challenges during project implementation, and one was low screening. By the start of this initiative, only about 15% of the eligible women had been screened for cervical cancer. That's by January 2024. We also saw suboptimal utilization of screening data by facility staff. And the other challenge was basically knowledge gaps among some of the service providers who were not well equipped with the necessary information in terms of sensitizing the clients such that they can embrace the screening. We also had challenges which were related to client misconceptions, and this deterred some clients from embracing the screening and being treated accordingly. So we came up with initiatives to ensure that we tackle these challenges and improve the uptake of cervical cancer screening and management amongst the 72 RT health facilities that we are supporting in Eastern region. Yeah, so we basically leveraged on a social media digital platform that's basically WhatsApp that is commonly used. And we saw that health workers, members of the community who are being termed towards cervical cancer champions, but also Ministry of Health officials and the implementing partner staff were able to use a similar platform to connect up with the facilities which were providing a service, be able to identify some of their challenges and provide real-time support using WhatsApp intervention among these facilities. So a group was created, and the group was basically called LSDA CXCA, basically meaning cervical cancer updates. And this group basically had all the relevant stakeholders. So after forming the group, we embarked on sharing data. Basically, this data was shared weekly, and it had performances. It had insights into how the different facilities were performing. On the right, we basically see a small snapshot of the dashboard, basically shared with the teams to air out some of their challenges, especially in reference to cervical cancer screening and management, but also share some of the success stories which were related to some of the cases that had been identified promptly and also treated on time. Yeah, so the digital platform enabled facilities to share those that were performing really excellently, to share what we were terming towards enablers, but also facilities that found challenges in terms of providing a service, cervical cancer screening to the women. We encourage them to utilize the platform to share the challenges such that they could be prioritized for support by Ministry of Health officials, by regional mentors, but also staff of the implementing partner, which was Uganda Protestant Medical Bureau. So the platform also enabled us to recognize the top performers, appreciate them, but also encourage some of the facilities that were finding challenges to share them real time. We're also able to offer virtual mentorship in terms of packaging the information, health sensitization to the women that were eligible for cervical cancer. And using the very platform, we're also able to prioritize for hands-on support, especially to health facilities that were not performing well, that were literally referring to here struggling sites during the implementation. Yeah, so this was basically the team. It was a multi-stakeholder engagement, and one, it had facility teams that were part of the data, and these were basically tracking and reporting numbers that were screened, but also had health unit in charges, and this basically oversaw implementation at the facility level, identifying some of the challenges, reporting the challenges to the implementing partner, but also the regional mentors and the Ministry of Health officials for support. Yeah, we also had the people we called cervical cancer champions, and these were basically responsible for mobilizing and sensitizing women for screening. These were also women who had been previously screened. Some of them had lesions that were identified, and they were managed or treated successfully. So part of their role basically was to share any challenges in the community, but also keep sensitizing the women to embrace cervical cancer screening. Yeah, we also identified facilities that were not performing well, and these were supported using the teams that we refer to as clinic mentors. These were health members that provided hands-on support, improved the skills of the screeners, but also supported treatment of some of the cases that had been identified at the facilities. So we saw progressively over time that there was improved performance in terms of screening for cervical cancer and treating the women that had been found positive, but also it enhanced communication, which communication was real time, because the WhatsApp platform is commonly used by a number of stakeholders, right away from Ministry of Health, the implementing partner, the facilities, cervical cancer champions, the data teams, as well as mentors. There's real-time communication, and so we're able to identify some of the barriers, especially for health facilities that were not performing well, and these were prioritized for support. We also saw that the consistent data use really improved when we were using this platform for coordination and reporting some of the success that we had basically seen. Yeah, so in terms of results, we saw that progressively, in a period of 9 months, we saw the screening rise from 15% to 91% by September. And looking at the absolute numbers, we saw over 4,820 women who were screened at the 72 LRT sites in the Eastern region. But also from these, we were able to identify 236 cases of women living with HIV that had precancerous lesions that had been diagnosed. And the team was able to successfully treat 225 cases at these health facilities, of course, using WhatsApp to report, but also to share some of the challenges and enablers for this project. Yeah, so overall from this project, we see and recommend that health workers, stakeholders, and various players can adopt virtual technical working groups because these enable real-time data use, and basically improve service delivery when we're able to share real-time data. We're able to identify challenges, but also provide guidance, especially to some of the health workers who may be at a distance from the mentor or from some of the Ministry of Health officials, as well as implementing partners. And also, I recommend that data is shared weekly, especially among stakeholders, because this enables the program managers to identify some of the data errors, but also focus on some of the issues that can improve programs at different levels. I also actually recommend that this approach is simple, is cost-effective, and quite a number of people are now using the social media platform, the digital platforms, and can provide a coordination platform for health workers, for Ministry of Health officials, and a number of other sector players who are basically providing different services to the clients living with HIV. And so we recommend that the model can also be embraced for other services. In Uganda, we're also now coordinating some of the local neonatal and maternity systems using some of the digital platforms and seeing improvement. Thank you so much for listening, and I welcome any questions. Thank you.
We'll have one question for each of the presenters. So I've seen one, so it means I'm taking 3 questions. So one hand here, a second one more. All right, I've seen you there. All right, thank you. So the mic.
My name is Dr. Elizabeth Ijare from the National AIDS and STI Control Program here in Ghana. My question is to Seth Gav. Okay, my question is about the AI. Now we hear about AI causing people to commit suicide online. Is there any safety measure for this particular app so that people will not commit suicide as they are talking to someone that's not human? Thank you.
Thank you. We'll take the second one from the gentleman right by you. Yes. And then please send the mic to the lady. Can you raise your hand? Yes, please. Thank you.
All right. Good afternoon. My name is Sondi from Nigeria, Center for Clinical Care and Clinical Research, Nigeria. My question goes to the BeWise app. So I want to understand, how do you manage the issue of data privacy, because your app is also WhatsApp based? How do you manage that issue of the data privacy? Because I can see on the app there's a place where they write profile. So how do you manage the profile and the data of those people that chat on the platform? Thank you.
All right, and then the last question.
Good afternoon. I'm Dr. Ntomfile Mjali. I'm from South Africa. My question actually goes to all the panelists, and it's related to the safety concerns as well as the privacy. But then specifically to the self-GAV presentation, I would like to find out what the pathway to scale looks like. You've mentioned that there are ideas that you have in terms of how it can be rolled out, but what does that practically look like? I note that you've got National Department of Health or Ministry of Health buy-in. How critical is that? But are there also resources for such a tool to be scaled up? Thank you.
Thank you. So, Madam Gertrude, or is it Mr. Potsane who will take the questions? If it's not working, because we don't have time, you can come here since this is already working. Thank you.
Okay, I'll start with the scaling out of the platform. Currently, we are mobilizing resources to make sure that we revamp and improve the site, because what works yesterday, it won't work tomorrow. So as a department with our partners, we are currently mobilizing resources for that. And we do not collect information on the AI that we are having, so there is privacy because we don't collect personal information on that. And the chatbot is compliance with the South African protocols that we have gone through it. Yeah, thank you.
Thank you.
I'll take the first question. I do appreciate you for attempting to say self-CAF. Whenever you come to South Africa, you must know that you are certified because of you pronounce it the way how it should be pronounced. But the question on the chatbot safety is that the chatbot was clinically validated by a group of local experts. And how the chatbot handles the responses, we've got a natural language processing models that monitor the chatbot safety. And we also have clinicians at the background that audit and ensure that there is continuous quality improvement on the chatbot. The reality of the matter is that young people are digitally enabled, and young people, they just need information, and they will be able to self-determine about, about their own health and well-being. And this is a privilege and a trust that we need to give to young people because of they are already searching for the information on Google, on other large language models that are not regulated like this one. This one was created by a human beings, was also created by young people, and the safety standard, they meet the South African regulatory standards. As Ms. Mbalatu was saying, they also meet international standard. And from that point of view, the chatbot, it is safe, for consumption. Thank you.
All right, thank you so much to our speakers. Can we give them a round of applause? And I'm sorry, but our time is fast spent. We've gone overboard by about 4 minutes. So I would encourage you to interact with our speakers outside. Thank you for your time and attention.